with some friendly neighbors, I think. We want to keep the time schedule. My name is Gerald Werner. I have the honor of chairing the second German session, and the Urgestein of snowmass, the German, who understands it, one of the original members of the snowmass meeting, Klaus Reifart, will discuss a topic that is controversial. Femoral or radial approach, this story ain't over.
Yeah, thank you, Gerald. It's definitely a very controversial topic, especially these times when more and more people switch from femoral to radial. If you discuss both methods, you at least have to keep in mind that there are some essentials for the femoral approach to be followed. It has to be a safe and easy puncture. If operators on a regular basis need more than 1 minute, they are beginners. They are not good femoral operators. You need also to keep in mind that the catheters have to be advanced atraumatically, and in 10% of the patients, it's necessary to use a hydrophilic 3-5 wire, or in 1% even a floppy wire, coronary wire, to get across the iliac arteries. When the procedure is finished, you need to keep in mind that the compression, the amount of compression has to be appropriate. And that means most patients need to have their compression in the cath lab and not wait on the ward till somebody else who had not done the procedure and is not interested in a good compression does it. Pressure bandage according to rules, and for obese patients, I recommend to use closure devices. The radial approach, I started to do a brachial in '79 according to the Zones technique, and then I switched to femoral because it was much more convenient. But then again in 1992, the procedure from the arm started to become more and more popular. It was invented in 1992, the radial approach by Felix Kimmene. And the reason why he invented that was just because we had huge problems with our bailout stentings. We used in these patients with bare metal stents, we used heparin plus Coumadin plus aspirin plus dextrane plus pasentine. And the consequence was that more than 10% of these patients had a severe bleeding complications, huge groin hematomas, blood loss, tremendous blood loss. And on the other side, 15% experienced acute stent thrombosis. So it was not the way we were treating stents now, of course. And it was always an odyssey between Scilla and Charybdis. So with the radial approach, this was much better. But then when ticlopidine came and aspirin, the dual platelet inhibition was, had much less bleeding complications and less stent thrombosis. Despite that, radial approach grew more and more popular, and the late guidelines of the European Society of Cardiology, 2015, recommend radial access over the transfemoral access, at least in all patients with acute coronary syndromes. So it's like if you discuss with radial operators, it gets very, very fast. It gets to some like a religion, and I think they feel radial approach is like the 11th commandment: you shall not use the femoral artery. What are the facts? There are 4 large randomized trials comparing radial and femoral in acute coronary syndrome. It's the Reifart, the Reifart Stakes trial, the STEMI radial, and the Matrix trial. Let's start with the Reifart trial. More than 7,000 acute coronary syndrome patients were randomized. The primary endpoint was myocardial infarction, stroke, and severe bleeding. And it was 3.7% in the radial versus 4.0% in the femoral group, not significant. Secondary endpoint was death, myocardial infarction, and stroke, again, similar. Major bleeding occurred more often in the femoral, but it was not significant, 0.7% radial versus 0.9% femoral. Access failure, radial, 7%. So they had 7% had to be crossed over to femoral. The conclusion of the authors of the Reifart trial was radial and femoral are both safe and effective. However, a lower rate of local vascular complications, that was 0.1% in the radial and 0.3% in the femoral, may be a reason to use the radial approach. I can't follow this conclusion. And on the other side, and in addition, radial occlusion, which occurs in about up to 10% of the patients, was not reported in this trial. Reifart stakes, 1,000 STEMI patients. Primary endpoint it was called NACE. So in addition to the MACE, it was target lesion revascularization and severe bleeding. 13.6% versus 21%. This was significant. The bleeding was defined as ARC above 2. It was 7.8% versus 12.2%. Though most of these primary endpoint difference was driven by bleeding complications. And it was defined as bleeding requiring intervention by healthcare professional, not necessarily by the physician, or increased level of care or prompting evaluation. So a quite soft definition. Secondary endpoint cardiac mortality, 5.2% versus 9.2%. That was significant, but the study was underpowered for cardiac mortality. Reifart stakes, the drop in hemoglobin, more than 3 grams percent, 6 versus 9.8%. Major TIMI bleeding, 1.8 versus 2.8%, not significant. But we have to keep in mind, if you see 9.8% bleeding complications with femoral approach, which is a lot, it's much more than I used to experience. We had different patient groups. The sheath size, more than 7 or larger, was 9.2% in the radial only and 18.6% in the femoral. 8% of the patients had pre-interventional thrombolysis, and almost 70% had to B3A inhibitor, a therapy that we at today are not offering our STEMI patients in that amount, in that percentage. 9.6%, so almost 10% had crossover from radial to femoral. So Reifart stakes is not convincing. It has shown a lower bleeding rate compared to radial approach, but the sample size is lower for mortality. The mortality was lower in radial, but the sample size was too small. And I think it was a biased comparison because we had larger sheath sizes in the femoral group and 70% had to B3E inhibitor. STEMI radial, 707 patients. Primary endpoint, major bleeding. Access site complication was 1.4% versus 7.2%. And the bleeding complication was according to the Horizon definition. Death, MI, stroke, major bleeding, vascular complications, 4.6% versus 11%. If we look at the bleeding complications, that was really a huge difference between two groups. We see that the major problem was a hematoma, not even a drop in hemoglobin of more than 2 grams. It was a hematoma larger than 15 centimeters, as you can see here. So this was the driving force for the difference in the bleeding complications. Radial occlusion, again, this trial was not investigated. So vascular access complications was studied incompletely. The Matrix trial, the largest trial, more than 8,000 patients with acute coronary syndromes. 3-day death, MI, stroke was 8.8% versus 10.3%, no difference. Again, in this trial, it was not described how the femoral approach, how the femoral closure was performed. Sheath removal, compression, not described, and was left up to the center. Bleeding complications, According to Gasto definition and TIMI definition, no difference. According to BARC, 3 to 5, 0.8% difference, that is 1 out of 100. Surgical intervention, 0.1% versus 0.4%, so not striking difference. All-cause mortality, there was a difference of 0.6%, and this was barely significant. And if you look at the study definition for significance for all other parameters, they use 0.025. But for mortality, they use 0.05. So it was significant, but it was just for the mortality, they lowered the significance level. If you don't believe the facts of the randomized trial, you'd cry for a meta-analysis. So in 2016, a meta-analysis was performed in more than 20,000 patients. They screened 855 publications comparing radial and femoral. 39 of these comparisons were randomized trials, and 24 were considered in the meta-analysis. So it's not quite clear why these they only considered 24 and not 39. The authors calculate, according to this meta-analysis, that radial approach is reducing mortality by 29%, MACE rate by 16%, severe bleeding by 27%, and vascular complications by 77%. This is very impressive, and everybody in this room is definitely now convinced that we should use radial approach, except for me. Radial occlusion was not measured. Not a single word of radial occlusion appears in the whole publication. And we all know that radial occlusion is not is a complication. If the radial artery occludes, it's a vascular complication, and this may occur in up to 10% of the patient. So it was not even mentioned. If you want to increase a difference which is not large, if you want to turn a fly into an elephant, what you do is you calculate relative risks. That means percent of percent. And this is in many medical publications. This is, to my view, this is a wrong perception. In the 4th grade of elementary school, at least in Germany, we learn how to calculate percentage. It's part of the whole times 100, that is percent, and not percent of percent. So if we get back to this meta-analysis, death all-cause was 1.6% versus 2.2%. MACE 5.6 versus 6.7. Major bleeding 1.07 versus 2.07. And major vascular complications 0.24% versus 1.12%. Coming back to the 4th grade, this is a reduction of mortality of 0.6%, MACE reduction 1.1%, severe bleeding 1%, vascular complication 0.9%. So now it's less convincing. So the meta-analysis showed that radial versus femoral has about a little bit less than 1% less severe bleeding, mortality minus 0.6%, but the femoral axis is very unlikely to be the cause of this difference in mortality. Why can I say that? I say that because we have a very nice combination of 3 large trials. It's more than 17,000 patients performed by Roxana Meran. And in this publication, they figured out that isolated hematoma were not predictive of subsequent mortality. But this is what we have as a difference between radial and femoral. We have an isolated hematoma. And if we see a slight difference in mortality, it's not because of the isolated hematoma. What happens to the radial artery after intervention? In up to 10%, and it's not mentioned in any of these trials, in up to 10%, we know that we have severe vascular complications leading to at least an acute occlusion of the radial artery. Sometimes it reopens, but how does the radial artery look after it had been occluded and reopens? It can never be used as a bypass graft, for example, or the nephrologist would not use it for hemodialysis. In a recent trial presented at the PCR last year, a Dutch group showed that 75% of the radial arteries are malfunctioning after 2 weeks, and 7.3% are occluded. So this is in concordance with other trials. Coming back to Felix Kimenet, 2 years ago, he was interviewed, and he said the company that will develop a device for opening up occluded radial arteries, that's a lucky company in the future. Why did he state that? Because he knows that radial arteries access may cause severe problems. So my view, to summarize, is radial access is safe and comfortable for the patient, but femoral is not less safe. Radial access is not good for complex procedures when we use 7 French or 8 French guides. More radiation for operators, has been shown in several trials, in randomized trials also, and in up to 10% we have severe radial injury, which is not reported in the trials, not in the meta-analysis. Up to 10% cross over to femoral, which is dangerous, quite dangerous in STEMI patients. So if I had to rewrite the 11th commandment, I would state, you may use the radial artery if you are sure that the patient does not need it in the future. Thank you very much.
Thank you, Klaus. Responses. Kari.
Thank you, Klaus. Well, I'm not worshipping the radial artery either. And there are a couple of problems you didn't mention that even after a normal, uncomplicated radial procedure, there is some motor dysfunction of the fingers for people who really need fine-tuning their finger movements.
Piano players.
Yeah. And another thing was that the slight excess mortality has never been directly, excess bleeding has never been directly connected with mortality.
Yeah, you're right. Yeah.
I think one point that is very relevant is, of course, a radial occlusion is a vascular complication. So the whole calculations would look different if it would really be taken into account. But I think I personally even learned the zones, even though I'm a few years younger. I had to learn the zones and came to femoral, and now I'm femoral radial because I think the development of the radial devices has improved. The problem is there is no real standard approach. There are discussions whether you need a cocktail to give into the radial or not. I know that people are not using the hydrophilic coated sheaths, which are important because they are less traumatic, because these sheaths are always slipping out. So people on purpose use sticky sheath. This is nonsense. We need a well-established and thorough analysis of how to do a radial approach perfectly. Of course, I do it perfectly because I have no radial occlusions.
I know, I watched you.
But it's a very important point. It's not standardized.
Yeah, but also the femoral approach has to be standardized. And in the studies, it has to be standardized. When is the sheath pulled? How is it compressed? When do you use closure devices? And so on. So
and the problem arises that what we hear from people who are training fellows, mainly radial, that they are not able to stick a sheath in the femoral properly. It's always a low puncture, often, most of the time, much too low punctures.
Yeah, then you get to the femoral profunda, which is very difficult to compress. Yeah.
Heuser, Phoenix, can I give a differing view? So we switched over completely 8 years ago. We saved $375,000 a year in expenses. We have patients from all over the country that move to Phoenix, which, you know, Phoenix is a destination area, but people move there from the Midwest. They specifically will come to see us because they've had interventions or they're at the adult age and they would prefer to have the radial procedure. In terms of training physicians, I think we do stand a chance that these young physicians, heaven forbid, are going to be using harpoons in the femoral arteries, and we're going to get a lot of retroperitoneal bleeds, et cetera. The only saving grace is, I think, the younger generation, pushed actually by interventional radiologists who do everything with ultrasound. And I think using an ultrasound for a femoral approach may be very beneficial for those that don't do a lot of femorals. But we've switched over and we haven't looked back. We've been very happy with it. The group from Austria, the gal that presented that at PCR, that has not been confirmed in any other center in terms of the so-called neurologic deficits. We've just never seen that at all.
Did you look for it?
Absolutely, because we see the patients back within the first 2 weeks. And the incidence of radial occlusion is probably in about the 4 to 5% range. And clearly in the future, maybe you want to do a procedure again, and that can occur, and that can be a problem, and you may have to go ulnar or have to go to the other arm. Or if it's a radial artery, that might be used as a bypass conduit. So those are real issues.
But Richard, if 5% are occluded, how many are injured and not occluded? And how many of these arteries can save as a graft in the future? I doubt that this graft is the same quality as an untouched radial artery.
I couldn't agree with you more. Show me all these surgeons that are doing these radial bypasses. I'll work there. I'll refer to them because the surgeons are not doing that anymore. I'm sorry. I wish they were. Not our facility.
Our surgeons do it, and the radial arteries are really good grafts.
No, that's good, and I think that you definitely don't want to go in both sides if you don't have to. But again, the occlusion rate it's low and it's getting lower.
Occlusion rate, yes. Injury rate is much higher. That's what the group in Holland showed.
No, I agree with you, and it's funny because talking to the surgeons, I always intrigued with high-volume surgeons, whether they're bothered by that, and they don't seem to be, but you've got a valid point. Thanks.
Okay.
One comment?
Yeah.
This should have been in the Danish session because this is like the Hans Christian Andersen story that the emperor had no clothes. It's very good that somebody is shouting out this fact.
No,
Thank
well,
you,
but there is no discussion, or it's no. All the points are marginal, and the radial occlusion, I think, is something that could be decreased by using the right sheath and proper protocols. Also the occlusion. Last year we had a randomized trial presented here from Russia where they showed in all 3 arms 8% occlusion. But the trick was they did an occlusion for 24 hours. Yeah? So, and it was surprising to learn that we occlude maybe just 2-3 hours after a radial intervention. Yeah. So there is so much unstandardized approach.
Yeah, but the main question is, do we have such a difference between radial and femoral complications that radial is necessary to write it as #1 procedure in the guidelines? I think no, we don't have this data.
Please.
I'm sorry, I am from Brno, Czech Republic. We moved from femoral approach to radial approach some 5 years ago. And for me, really, a radial approach, and I was femoral interventional cardiologist. For me, it's a revolution in interventional cardiology. While I can see that the patient, they can immediately after diagnostic procedure or after 2 hours go home and leave the hospital after femoral approach. They had to stay overnight. Also, for example, this difference in mortality, I think, is caused because the patient had to stay in the bed for, we can say, for many hours, and then you have more of pulmonary embolisms, more sepsis, etc. I think by this difference in mortality can be explained.
Well, that's your guess. But on the other hand, we have done four French femoral, Hans, you are here, since more than 15 years. The patients leave the hospital at 2 hours. They step up after 1 hour, we see the groin again after 2 hours, and then they leave the hospital. No complications, zero.
But no, we don't, we have Richard now. Let's move on. The thing is, one final comment by the chairman. There shouldn't be a switch from one to another. I do both when I need them. I do all my left main rotablation with radial, but there are instances when you need a femoral approach. So we shouldn't say I become a radialist. You should still remain a coronary interventionalist.
I absolutely agree with this. Do 90% radial and 10% femoral. But for most of the patients, I think, especially diagnostics, it's clearly better to do radial approach.
No, it's not true. You get worse images. Look at the cineangiograms. You get worse images, and you get, my patient are leaving the hospital after 2 hours. So what's the difference?
Okay, I am sure that I have better images with 6 French or 5 French.
No,
than
4
with
French.
4
French.
With 4 French diagnostics, the images are not so excellent.
Yeah, but they're sitting better. The seating is much better.
Yeah, it's a matter of training. Yeah, so everybody who does one thing 100 times is better in this field than if he does one thing only 10 times.
Maybe just tell a small story. When I gave this presentation 4 months ago, one of the cardiologists, interventional cardiologists, age 71, stood up and said, I'm a radial operator, and I prefer radial. And I had an infarction, and I was treated, I had acute PCI. What I would love to have my operator do is use the technique he feels most comfortable. If it's femoral, he should do it femoral. If it's radial, he do it radial. So that was a radial operator.
Yeah. Final word before you give the next talk.